SIRS and MODS. So you have something like shock that will initiate SIRS. SIRS leads to MODS, and MODS affects, well, I'll get to that in just a second. MODS affects 2 or more organs. So, heart, lung, GI, liver, CNS, renal, skin. MODS, multi-organ, right? Multiple, 2 or more organs are affected, or all of them. When we talk about sepsis, that is SIRS plus an infection. Okay. So, SIRS is a non-specific systemic inflammatory response to a variety of insults. It doesn't need to be an infection. When we talk about sepsis, that is SIRS caused by an infection. It's a little confusing. But SIRS is non-specific systemic inflammatory response. Bless you. So in general, there's inflammation in organs remote from the initial insult. What do you think that means? So I'll show you some examples. So something like a crush injury. You have a crush injury, meaning that, like, let's say those poor people in Mexico, right? The earthquake, and they had rubble fall on them, and you know, their arm gets crushed. SIRS, they would start having respiratory symptoms because mediators get released, and you have kind of this systemic inflammatory response, but your lungs are affected. Or you have an abscess form, but your kidneys start failing. You have an abscess like on your butt or your back, and then you notice decreased urine output because you're having some kind of systemic, so systemic means whole body, right? Inflammatory response to some kind of this insult. It can be necrotic tissue, like an MI. It can be from microbial invasion, so some kind of infection, but doesn't have to be. It could be from perfusion deficits. Oh, is that shock? Yeah. Right? So a bunch of different things. So when we talk about sepsis, that is SIRS caused by an infection. And there's sepsis criteria. We are teaching you sepsis criteria because that is currently what we in the NCLEX are testing on. You might see in practice that that's going away. They're changing that up a little bit. Some places still, how many of you work in places that still have sepsis criteria? Yeah. I mean, there's still several hospitals that have it. Huh? Yes. And it's like a alert on the computer. Some hospitals are getting away from it. So you may or may not be seeing this in practice. But for now, this is what we're going to go for. So just to keep in the back of your mind, like when you get out next semester and you're like, Dr. Daniel said this, and you want to curse me out, remember, nursing is changing and evolving. So, but in general, we're going to talk about sepsis criteria, which is SIRS plus an infection. They're going to have a temperature greater than 38 or less than 36.
Why is it being phased out, the criteria?
I think they're finding different ways to alert us faster.
Are you seeing a reduction in septic incidents?
I don't know that, so I can't education. I can't give you an educated answer on that. I could make some stuff up if you want it, but but I really don't know why. So the facilities I work at still have it. So, but I know that there's talk that there's articles that are coming out, new research and stuff. But I'm not well enough versed to. Heart rate greater than 90, respiratory rate greater than 20, or a CO2 less than 32. And then a white blood cell count of greater than 12,000, less than 4,000, or greater than, this at the bottom, it says greater than 10% of immature bands. All right. So again, SIRS is you're having some kind of inflammatory response. Again, you have that crush injury, you have that heart attack, and it's not like, yes, you have the heart attack, or yes, you have the crush injury on your leg, but then you have some kind of inflammatory response that gets activated, and and it's remote, right? So not where the injury itself happened, but away from it, like you start having lung failure or kidney failure or something else happening. But that's one organ system that fails, okay? If it's because, and this is where this kind of shows, sepsis, right, which is sepsis criteria, is SIRS plus infection. So SIRS caused by infection. That's the criteria that we use. Many of you will see that your organization will have like little dings that if your patient, is this very easy to have a patient with a greater than heart, I think 2 or more is what they trigger sepsis criteria. So could you, I mean, how many of you have taken care of patients like daily that get heart rate greater than 90 and a respiratory greater than 20? All the time. So I think that's why they might be making some changes, is to be like a little bit more specific so we can hone in on those so that people don't get used to just being like, huh, they're on sepsis alert, you know. So, but that's SIRS. It's one organ system. MODS is 2 or more. So SIRS kind of progresses to MODS. So then hemostasis can't be maintained without intervention, and again, it results from SIRS. So you start off, the building collapses on you, you have a crush injury on your leg, you start having one system failing, and now like your lungs are failing, and now your GI starts failing, and now your renals start failing, and now everything starts shutting down. And it will continue to progress until death if we don't intervene. So what's our priority then? It's all about the perfusion, right? We want to perfuse the organs because we want to prevent organ failure. If MODS is 2 or more organ systems failing, I want to stop them failing. So what's happening in general? There's organ and metabolic dysfunction. So you have this inflammatory response. The mediators are released. It directly damages the endothelium. This causes hypermetabolism. At the same time, that direct damage to the endothelium What do you think it's going to happen to our vascular? Where do you think fluid's going to go? Out, right? It's going to be more permeable. Vasodilate. So you're going to get tissue edema. So if you're losing fluid, right? There's that. So the inflammatory meters get kind of sent into overdrive. They damage that endothelium. On one end, they're causing some hypermetabolism. On the other end, they're causing vasodilation. So, right, now we've got our same amount of fluid in a bigger space, and that fluid is leaking out. So tissues are getting edematous. That coag cascade gets involved. Oh my God, could that be DIC? Obviously, we're not perfusing, right? So decreased perfusion, decreased blood pressure. We get microemboli. And all of this hypermetabolism, the coag system cascade, the compromised perfusion, is all going to lead to decreased organ perfusion. So that's what's happening in general. And it starts with one system. So in SIRS, it starts with one and then progresses into MODS if we don't intervene. Oh, I'm sorry. Take a breath. That's okay. Is everybody okay now? Can I make the switch? All right. So what system is you think affected first? Now that I've said it 27 times. Oh my God, you guys listen to me. You're waking up. Why do you think ABCs are so important? So, often the first system to show signs of dysfunction. So again, that endothelium gets damaged. That increases capillary permeability, all the stuff we talked about in general. What do you think is happening to our alveoli? What are they doing? Filling with fluid. What does that sound like? ARDS, right? Yeah, it sounds like crackles, you're right. But it's coming all together. All right, so they're getting alveolar edema. What's happening to our surfactant? Because our alveoli are normally like, right, we breathe in. But now we're like, and it's so filled with fluid, I can't breathe out. What happens to that old, yucky, stale balloon? What happens to the surfactant? It goes down, right? We develop that atelectasis. So now we have these shriveled up old alveoli that can't really expand like they need to. They're filled with fluid. So this is a system failure. SIRS leads to something like ARDS. Let's look at the cardiovascular system. So we got hypotension, right? So decreased blood pressure, because again, we have that endothelium that's being damaged. We're losing fluids. So our blood pressure's down. We already said that. So tissue demands are low, right? Is the myocardium working the same? Nope. We already said. So it's, the resistance is going to be down, blood pressure. But when you get this hypotension, your body's trying to compensate initially, right? They activate that sympathetic nervous system and say, oh, we know that that heart's not working the way it should. So we're going to try to compensate. So we're going to try to increase cardiac output by increasing heart rate and increasing the systemic vascular resistance. Except for in which one? Neuro, thank you. And then we talked about the capillary permeability, right? Because this is happening everywhere. Fluid shifting out of the vascular space. Albumin is leaking out. Albumin leads, water follows, right? So if fluid is shifting out of the vascular space, do we have as much fluid coming back to the heart? Because as it's getting pumped out, it's just getting pushed out into extravascular space, so it's not coming back to the heart. So you have that decreased venous return. What's happening to our preload? It's down, right? So you're going to see, so if your cardiac system is the first one to go, it's not normally the first one, it's normally lungs. But if your cardiac is the first to go, or your cardiac starts failing also because now you're developing MODS, you're going to see things like your patient might be warm, heart rate, right, because it's trying to compensate. It's going to have decreased capillary refill, right, because we don't have, it's everything shifting into the tissues. So we don't have good capillary refill. It might be mottled. Because you have that increased capillary permeability and you have the fluid shifting out into the tissues, they tend to be a little warm. So like all your fluid is, I'm trying to explain it. Am I making sense or not? Okay. I feel like I'm not explaining it. So when you have like all the fluid inside the vessel and it kind of leaks out, all this fluid that's in here, you're feeling in the tissue. That's why they're warm. Yeah.
From that, and so it's still warm from the core.
Yes, initially. These are all in the beginning. Neuro. Again, hypoxemic, right? Capillaries are leaking, they're permeable. We have decreased cardiac output because we have decreased venous return. Blood is not getting to the brain. So we have those mental status changes. So it's all the stuff, MODS is all the stuff we've already talked about. It's just putting it together. When you have a patient that's in ARDS and is having mental status changes because of it, they have ARDS, that's their diagnosis, but because other systems are also being affected, then you have MODS happening. Does that make sense? Renal system. Again, is it being perfused? No. Because we have capillary permeability, fluid is shifting out, decreased venous return, heart can't pump out as much fluid, so it's not perfusing the renal system. That, oh, bless you. Sympathetic nervous system, RAS system, gets activated. So they try to kind of vasoconstrict. to help get perfused. They're trying to get aldosterone. So this is all the things going on. So what if our kidneys aren't getting perfused and they're trying to compensate here, right? They're activating the sympathetic nervous system. They're saying, come on, vasoconstrict so I can get as much blood as possible. Retain some sodium in water, because the more sodium in water I keep, I'm hopefully going to push more fluids into my system, right? So if all that's happening, what are some signs and symptoms that we're going to see with the renal system? Decreased urine output. What about labs? Yeah. BUN, creatinine are going to be what? Elevated, right? So, and a lot of times, a lot of the antibiotics we use, because we said that SIRS starts from a bunch of different things. But a lot of the time, it's because of an infection. An infection initiates it. So, if we have an infection and we're treating the infection with antibiotics, a lot of those antibiotics are what? Nephrotoxic, right? So now, we've already got a compromised renal system. So if we are treating sepsis, which is SIRS with an infection, and we already are seeing like respiratory component, because that's, you know, it went first, and now we're treating with antibiotics, could we send our patient into MODS by causing renal failure because they're already at risk? So we're going to have to be careful. GI, this has a really key role in the development of MODS. So respiratory tends to be the first to go, but GI a lot of times will then kind of fail, and that's when the body starts going into MODS. That's why we feed them. We give PPIs. That's why we do that, because we want to prevent any complications. Is it all coming together? Oh, you guys lost your enthusiasm again. Am I going too fast? I'm sorry. Tell me to slow down if I'm going too fast. So again, motility is decrease in critical illness, right? Because we're all focused on everything else that we forget to start those feeds early. We forget to initiate that PPI. So they develop a paralytic ileus, they get some abdominal distension. And early, blood gets shunted away. Is the GI system a critical system? Is it the lungs or the heart or the brain? No. So blood will sometimes get shunted away. If blood's getting shunted away, is that organ getting perfused? No. So if it's not getting perfused, it's going to die off. So they're higher risk for ischemic injury, right? If we feed that bowel, will blood come? If you have it, yes, right? But if you don't activate that GI system, your body's going to be like, they're not using it. We don't need it. So we're going to shunt blood away to organs that are working right now. The blood or the heart's working, the lungs are working, the brain is working. So we'll shunt blood away from that bowel. That bowel then starts to die off. So if it's died off, that nice protective mucosal barrier is going to go away. So if you don't have that nice protective barrier, that bowel is ischemic, it's dying off, you're going to develop an ulcer. What happens if that ulcer erodes? You're at risk for GI bleed, right? What's inside your gut? Bacteria. Is bacteria in your gut good? Yeah, no. In your gut. In your gut, is bacteria good? Yes. Out of your gut, is it good? No. Okay. So if you now are ischemic and you're developing ulcers, not only can those ulcers break open and bleed, those ulcers are now giving a portal for normal bacteria in your body to get out into your abdomen. You'll become now septic and sepsis and peritonitis and everything else. So you're making your patient sicker. Again, that's why we start feeds so early, because if we start feeds, is blood going to be shunted? Yeah, because it's going to want to help aid in digestion. Because it's saying, oh, it's working, let me send blood.
Is there like a preferred oral for the feed?
You always want to start with the best is oral always. And then you can put like an NG tube, and then go to TPN if you need to. But TPN's not going to really initiate the gut as much. There's a lot of writing. Stop. Take a breath. Stop. Don't write. Everyone look up at me. Ready? Let's breathe together. Don't write all this down. Okay? It's okay. Again, these are all just how each system is breaking down. Can all the systems be breaking down kind of at the same time? Can all this be happening at the same time? Can one be happening and then cause another? Or that one cause the other? Right? Yes. So there is no rhyme or reason to how they start breaking down or which one does first. Well, there's a little bit of rhyme and reason. But all you have to kind of know is that glucose not working, liver dysfunction. Okay? This is what's happening. If they're having liver dysfunction, what are you going to see? How are you going to know your patient's in liver failure? Yellow skin. What else? What could be subtle? Liver enzymes. Yes, Brianna. What? What are you going to see? Yeah? What else? If the liver's not working, what's connected to the liver? Pancreas is kind of, right? We're going to get that in the next test 4. You'll get that a little bit more. Amylase and lipase. So could you see on your CMP or BMP, everyone know what that is? Complete Metabolic Panel, basic. Could you maybe see some subtle changes? So if you have a patient with ARDS and you get lab work the next day and you're like, oh crap, amylase and lipase are a little elevated. Liver enzymes are elevated. We haven't started feeds yet. I could be sending my patient into MODS, like every organ. Like those are early signs and symptoms that you guys should be red flags in your mind going, this patient's at risk.
Misty,
Mm-hmm. That's
sorry. With SIRS and mods and sepsis and stuff, does glucose goes up?
Mm-hmm.
And with other shocks, like in that one question, that's why I picked the sugar one. The other shocks, does this happen as well, that the glucose goes up?
Well, initially it goes up, but eventually stores run out and they bottom out. So they initially, but shock, you're not worried about, I don't want to say you're not worried. You're not worried about sugar with shock. You're worried about cell death. So that's why that one. It's the tissue perfusion. It's the cell death. That's your concern with that.
More of a concern.
Yes.
Thank you.
Uh-huh. Okay, again, stop, breathe. You can review all of this in your chart, but this is all the stuff you've already learned all semester long. Your hematological system, that's why we talked about DIC. So what are you going to see on lab results? What's going to be your FSPs? What are they going to be? High, good job. What's your platelets going to be? Low. What's your PT, PTT, INR? High. Okay? Your electrolytes, they're going to be out of whack, right? So all of this is all the stuff we've already talked about. So all these things are syndromes, right? Something caused it, and if we don't intervene, we're going to make it worse. And that's what SIRS is. It's one system that starts to fail, and it progresses to MODS where all systems start to fail. So our jobs as nurses is always early intervention, recognition, and treatment as fast as we can. So our goal is prevent progression of SIRS to MODS. We don't want it to get any further. That's why if we notice subtle lab changes, we don't blow them off and say, well, you know, normally amylase and lipase are, I don't even know the correct numbers offhand, I'm sorry, like 12, and now they're 14. So that's not that big of a deal. It's not that high. Well, that should be, if in the looking at it solely, no, it's not a big deal. But if I'm looking at a patient that has ARDS, that's sick, that's a big deal because that means everything is shutting down for that patient. It's the beginning of everything shutting down. So early signs and symptoms. So we're going to prevent infection, right? Strict aseptic technique. So changing lines, that's why we're such sticklers with making sure that we completely aseptic. We want to prevent any infection because infection plus SIRS equals sepsis. What are other things that cause infection for a patient? Like besides invasive lines? Why do we ambulate them early? Or pulmonary management. Why? Atelectasis, which could lead to what? Pneumonia. Or if respiratory is the first system that could be affected or the most at risk, don't we want to be really aggressive with that? That's why we use that incentive spirometer. That's why we're going to get them up, because we want to get those lungs working. Maintain tissue oxygenation. The whole problem with shock and SIRS and MODS. What's wrong, Darian? Are you done? I saw your eyes closing. I know, I'm sorry, I didn't mean to call you out. I'm trying, man. I know, it's a lot of info. All right, so the whole problem, right, is that our demand is greater than our supply, right? So with shock, there's no tissue perfusion. So we want to decrease the demand and increase the supply. Does that mean that they may be sedated? That they may need to be put on a vent? If they're working really hard to breathe, is their demand higher? Yeah. So that might be then, like, that's why we said vent is supportive care, not treatment. A lot of times we put patients on vents to let their body rest while they're healing from something else. Or so that they don't have to work really hard and tire themselves out breathing, because ABCs, right? We want to make sure breathing's taken care of so that we can move on and treat what else is going on. Nutrition, we've talked about this. That's why we want to feed them. And that's what I would write, feed them. That's why we start the PPIs, because remember, the GI system plays that key role. If we're not using the proton pump inhibitors or the H2 blockers to prevent any ulcer formation, they could develop an ulcer, they could bleed, we could get bacteria released. And then as systems fail, all the stuff we talked about, as those systems fail, we provide supportive treatment for those systems. So if it's the lungs, ARDS, they get put on a vent. We increase the PEEP. If it's DIC, we're going to go ahead and give a low molecular weight heparin and FFP. So we're going to help them clot by breaking up clots, right? If it's renal failure, they might need dialysis, which you guys are going to talk about in the next test. So all of these are syndromes, and that's why it's so important for you guys to recognize those early signs and symptoms so we can start treatment. Because everything we're doing is supportive care. That for ARDS, for DIC, that doesn't, if we don't treat the underlying cause, it's going to continue to happen. That's it. All right. That wasn't too bad, right? All right. So when caring for a patient with cardiogenic shock and possible MODS, which information obtained by the nurse will help confirm the diagnosis of MODS? Who wants A? Who wants B? Who wants C? Who wants D? All right.
Because it's more than one system.
It's more than one system, right? SIRS is one. MODS is more than one.
So you are gonna see the crackles.
Because that's all with cardiogenic shock, right?
Okay.
You see where you got to put that picture together? I know it's a little hard. But cardiogenic shock mimics what? Heart failure, right? So if cardiogenic shock mimics heart failure, you're going to see signs and symptoms of heart failure, typically left-sided. So you see crackles and chest pain. So those are going to be normal. So all those other answers, the crackles, the chest pain, the cool extremities, those are all signs and symptoms of cardiac shock already. What's the one that's different? Yeah, we added another system. So that's what it's looking for. What added another system to it?
So when we see MODS, we wanna, okay, let's,
We need two systems. I need signs and symptoms from two different. So I'm going to have cardiac symptoms and I'm going to have the liver involvement or I'm going to have some GI involvement. And that's why they're going to have labs that are abnormal. We have to put that picture together.
But it says possible, it doesn't say it's not.
Oh, Tony. Okay. We will talk after class. I don't have a fight left in me. I'm sorry, y'all. To monitor a patient with severe acute pancreatitis for the early organ damage associated with MODS, the most important assessment for the nurse to make are... Okay, so it's saying, what is the question asking you? Right? MODS. MODS means what?
more than two or more systems.
Two or more systems. What system does it tell me it's already affected?
The pancreas.
Okay, so the system. So I need another system, right?
Right.
Which system is mostly affected?
B, respiratory.
You said liver was next to pancreas.
Right?
Respiratory. Yeah.
Respiratory's early on. Okay? It's typically one of the first systems to go. So if you have a system failing, if you have one system failing, a lot of times respiratory is either the first or the very next one to fail.
Or ABCs.
Always ABCs.
Respiratory.
Okay. So it seems very confusing, SIRS and MODS, but it kind of, like I said, ties together all the things you already know, right? Or you're going to know this weekend.
Just absorbing it and just.
And